Welcome! In the next few minutes, we're going to break down 3 brand new studies that are absolutely going to change how you practice. We're talking about a new playbook for steroids, a protocol for brain bleeds that saves lives, and a really eye-opening look at how our words can make or break the family experience. Let's get right into it.
So, let's start with a situation we've all been in. You're on ICU rounds. Your patient is in refractory septic shock, already on their 3rd pressor. You're thinking about steroids. Is that the right move, or is it just a shot in the dark? Well, we're about to find out what the brand new 2024 guidelines have to say about that.
And for our second question, we're going to shift gears. Let's talk about an intervention that's just as vital as any drug, but it has nothing to do with pharmacology. It's about our words. Imagine you give the exact same difficult news to 2 different families. How is it possible that one family leaves feeling supported while the other feels completely dismissed? New research has uncovered some really profound patterns in how we communicate, and we need to talk about them.
Okay, let's kick things off with the pharmacology. We're diving into the major 2024 update on corticosteroids. Our first source is hot off the press, the 2024 Focused Update Guidelines on Use of Corticosteroids, which was just published in Critical Care Medicine. This is a huge deal for all of us in critical care. And just so you know, the links to the bibliography are in the description below.
So to really frame this whole discussion, I want you to think of this metaphor. Steroids, they aren't a magic bullet. They're not some simple on-off switch. A much better way to think about them is as a skilled conductor for an orchestra. And in things like sepsis or ARDS, that orchestra, our inflammatory response, is just a chaotic, damaging mess. Steroids are the conductor that steps onto the podium to quiet that cacophony and bring back some harmony.
And here it is, the new clinical playbook at a glance. For septic shock, the guidelines now suggest using corticosteroids, though it's based on low certainty evidence. For ARDS, it's also a suggestion, but this time with moderate certainty. Now, for severe community-acquired pneumonia, it's a strong recommendation with moderate certainty. And this is really important for sepsis without shock. There is still no recommendation to use them.
Now, the biggest practice change here is definitely for ARDS. You remember the old 2017 guideline limited steroid use to patients who had a PaO2 to FiO2 ratio of less than 200, while the 2024 update gets rid of that qualifier completely. So the big takeaway is that the indication has broadened. We're now talking about all critically ill patients with ARDS, no matter what their initial PF ratio is.
All right, so we've covered the systematic use of a single drug. Now let's talk about a systematic bundle of care. We're shifting from inflammation to intracerebral hemorrhage with the landmark INTERACT-3 trial.
Our source here is the INTERACT-3 trial, which was published in The Lancet in 2023. This was a massive international study that tested a very specific, protocolized care bundle for patients who come in with an acute intracerebral hemorrhage.
And the best way to think about the INTERACT-3 bundle is like a pit crew for the brain. It's not just one thing. It's a series of rapid coordinated actions all happening within that first critical hour. We're talking about aggressively getting that systolic blood pressure down below 140, managing glucose, treating any fever, and rapidly reversing anticoagulation. It's all designed to stop secondary injury in its tracks and save precious neurologic function. And the results? They were absolutely striking. The number needed to treat to prevent just 1 death was only 35. For a condition as devastating as intracerebral hemorrhage, where the mortality is just sky high, an NNT of 35 is incredibly powerful and clinically meaningful. This protocol flat out works.
And if you look at the primary outcome on this chart, you can really see the impact on functional status 6 months down the line. That bar on the right, that's the care bundle group. They had a significantly lower rate of poor outcomes, we're talking death or major disability, compared to the group that got usual care. This wasn't some tiny marginal benefit, it was a really substantial improvement in patient prognosis. Okay, we've talked about what to give and what to do. Now we have to talk about how we communicate. Because this next study makes the case that for the families of our critically ill patients, the conversation we have with them is the procedure.
This research is from a 2024 study in JAMA Internal Medicine. What the investigators did was they actually audio taped real family meetings in the ICU, and then they analyzed how the clinicians' communication was different when they were speaking with Black versus white caregivers. And I have to tell you, the findings are pretty sobering.
So listen to this first example. A white caregiver is talking about their fear of the word tracheostomy, and the clinician immediately validates that emotion, saying, when you first hear the word, it is, and it's very overwhelming. That's empathy. That's a connection. Now, listen to this second exchange. A Black caregiver is expressing fear about what's going to happen after the ICU. The clinician's response? "So, we'll talk about it when the time comes. Now is not the time." The emotion is just pushed aside. The connection is completely missed. The difference between those two quotes is just, wow.
So when the researchers analyzed hundreds of these conversations, 4 consistent and, frankly, troubling themes emerged. Clinicians provided less emotional support to Black caregivers. When Black families would express their trust or gratitude, it was often just met with silence. They were given less detailed medical information, and, crucially, their preferences for continued life-sustaining care were more likely to be challenged.
So we've got steroids, we've got a brain bleed bundle, and we've got communication. The big question is, how do we pull all of this together and actually use it at the bedside? Let's synthesize these 3 studies into a clear, actionable framework.
Here are 3 key clinical takeaways. Number 1, know your playbook. You've got to master these new 2024 steroid guidelines for sepsis, ARDS, and CAP. Number 2, systematize urgency. The INTERACT-3 trial proves that having a protocolized care bundle for time-sensitive emergencies saves lives. And number 3, treat communication as a procedure. We need to approach family meetings with the same planning, intention, and skill that we would for an intubation or a central line.
And if you want a really simple way to remember the theme of today's entire explainer, here it is. 3 words: evidence, empathy, equity. We have to be guided by the best evidence, we have to deliver it with genuine empathy, and we have to do it for every single patient, ensuring equity.
So here is your call to action. I want to challenge you this week to audit your empathy. Just pick one family meeting. That's it. And in that meeting, make a conscious effort to do just one thing. Either verbally validate an emotion that you hear someone express, or verbally acknowledge an expression of trust or gratitude from the family. See what happens.
That's all for this explainer. Disclaimer and bibliography in the description.